now introduce Dr. Mark Fear, a Senior Research Fellow in the Burns Injury Research Unit at the School of Biomedical Sciences at the University of Western Australia. And Dr. Fear has conducted the preclinical work on the Pharmaxis LOX inhibitors and will cover the science of scarring and potential LOX inhibition benefits. And then followed by Professor Fiona Wood, who leads the Burns Service of Western Australia and is a director of the Burns Injury Research Unit at the University of Western Australia. Professor Wood is leading the clinical trial programs into PXS6302 that Gary mentioned, and will cover the clinical applications of LOX inhibition and the unmet need in the clinical development strategy. Following the presentation by the two researchers, we will then have a period of Q&A with some panelists, which I'll introduce after the presentations. Thank you.
Okay, so I'm assuming everyone can see that okay. I'm going to talk about the PXS6302 treatment and the amelioration of scars. So as Michael said, I work with Fiona at the Burn Injury Research Unit over in WA, and I have done for the past 15 years or so. I'm just going to introduce some of the background as to why LOX is a good target in scarring, and then present some of our preclinical data using PXS6302 to improve scars. So when you get an injury, there's a process of sort of overlapping processes that result in healing. So you get initially the platelets, and you get fibrin, clot, and hemostasis, so you stop the bleeding. And that triggers an inflammatory response. And this all happens, you can see across the top there very early, within minutes. And the inflammatory cells come in, they clean up that wound, and also secrete a whole bunch of factors that stimulate the next part, which is kind of the formation of the new tissue to repair what's been lost. So you have essentially two layers to the skin. There's the epidermal layer, the sort of surface layer, and that forms the barrier. And this will sort of migrate over across and form a complete barrier to restore the surface of the skin. And underneath you have the dermis, and this is what provides the platform for that to actually happen. So in the dermis, you have these cells, fibroblasts. They produce a lot of collagen, a lot of matrix. And once they produce that, these cells on the surface can migrate over the top of that and close the wound. And so what you're left with at that kind of early stage is a lot of fibroblasts in here producing a lot of matrix and a closed wound. And once that wound closes, obviously it's not susceptible to infection, but this looks very, very different to the surrounding skin, primarily because that matrix that has been produced to kind of promote healing is very different to the normal skin matrix in the tissue around it. And that happens depending obviously on the size of the wound over a kind of period of days and weeks. And then once you've got wound closure, there's a kind of process of remodeling. And this really continues for life. So sort of cutoff is around 18 months and you think you've got a stable scar. But even in stable scars, this process of collagen turnover and collagen production kind of continues forever. And primarily the reason scars look different and the reason they're stiffer and they feel different to normal skin is all about this layer here and the collagen that's produced by these fibroblasts in here. So the more of that collagen you have, the thicker the bundles, the more densely packed it is, the tighter cross-linked it is, the worse the scars. So there's kind of a whole range, obviously, from normotrophic scars, which actually look quite similar to the normal skin, all the way through to hypertrophic scars, which are raised and red and really obvious. And then obviously you have even fibrotic disease where scars actually grow outside of the boundaries. And this process, as I said, takes months and years. And this is what I'm going to talk about a little bit more now. So looking at these kind of two layers of the skin, so in normal skin you have the surface, and then underneath the collagen is kind of oriented in a whole bunch of different ways, and that provides a lot of kind of tensile strength and pliability in all different directions. What you have in scar is this collagen is much more densely packed. There's a lot more of it, and it's really tightly bundled, and quite often in sort of parallel bundles. So this doesn't give you that same kind of pliability because and strength, because all of the strength is in one direction. So I kind of hopefully sort of emphasize the importance of collagen in scarring, is just talking about, so here's the fibroblast here, which is responsible for collagen. So these cells are the cells producing collagen, and there's a whole bunch of stages as within the cell where they slowly develop from pro-collagen through to the triple helix that's actually secreted. And then outside of the cells in the actual matrix and the bit that we're kind of interested in, the collagen still gets processed even further. So some ends get cut off. And the very final step of this collagen, once it's in the matrix, is down here at the bottom. And it actually gets cross-linked. And this cross-linking is what's what's catalyzed by lysyl oxidase. So the lysyl oxidase enzymes cross-link this collagen, and that essentially makes it very, very stable, pretty much insoluble, and very hard to remove. And so this is where PXS6302 is effective. So PXS6302 is an irreversible inhibitor of lysyl oxidase. So that blocks this kind of cross-linking process and will reduce that stability of the start to degrade they will start to degrade the collagen back to the soluble, and you get this kind of balance between synthesis of insoluble back to soluble, and that's what gives you your normal skin balance. And then when you get scars formed, or as scars are maintained, you have an increase in LOX activity, an increase in that cross-linking. There's more of that insoluble stable collagen. The degradation's less, so the balance is just shifted, and that's what causes the loss of pliability and the increase in collagen and the poor scarring. And so obviously with PXS6302, you inhibit the LOX, you decrease the activity, you decrease the cross-linking. So you're kind of shifting that balance back now to increasing degradation. So over time, those scars will remodel and you'll increase the degradation of that insoluble collagen back to soluble. You change the balance and that should shift the balance back more to normal skin, which is what you want. And so just to run through some of our sort of preclinical data. So this is just looking at cells in culture, just to demonstrate something that we're pretty confident that inhibiting LOX does actually reduce the collagen and cross-linking from fibroblasts. So we just take fibroblasts, these are human fibroblasts in a flask in the lab, and we can add the inhibitor, PXS6302 or a LOX inhibitor, and then measure how much collagen is produced and look at also the number of cross-links that are produced. And this just shows as we increase the dose of the inhibitor, we reduce the amount of, so hydroxyproline is just a measure of collagen, and we also reduce the cross-linking. And this is kind of seen in these pictures here. So on the left is the control, which the green is actually just fluorescent collagen. So we've stained the collagen with a fluorescent label. And you can see there's a lot of it, and it's actually quite parallel in its secretion. And that obviously is reduced significantly when we treat them with the LOX inhibitor. I think as Gary kind of mentioned, this is a topical drug. So we've had to demonstrate obviously that this penetrates the skin. So the simple way to do this is a France cell. So you have a donor chamber, and in here we have the PXS6302 cream. And then we put a piece of human skin in between this and the bottom chamber. And then you can take samples from this bottom chamber over time. And obviously as the 6302 penetrates through the skin, you start detecting it in this lower chamber. And what we saw is over time, you get an increase of concentration of PXS6302 passing through the skin. And this is human skin again. So we know that the drug is actually readily absorbed into the skin and readily crosses the skin barrier, which is really important because delivery, I think, has been one of the big issues in terms of having effective treatments for scar. And so moving into a couple of preclinical models. So we've done 3 preclinical models. So our first is a small animal model, and this is an excision injury, so a surgical injury of full thickness. So through both the surface layer of the skin and the bottom layer of the skin where the dermis is. And then we treated once a day for 28 days with PXS6302, and then we look at the scars at the end of that experiment. And again, as you can see from that graph, clearly as we increase the concentration of 6302, we're effectively decreasing the cross-linking. And these pictures of the scars kind of show a nice histology. You can really see that parallel kind of striated collagen in here in the control, which is significantly diminished in the treated group when you compare that. So you can really see a change in the histology of those scars, as well as changes in the collagen and the cross-linking, which we measure. And so moving into a large animal, so this is the sort of standard preclinical model is a porcine model. And this again is an excision injury, so a surgical injury. These were larger, so 10 square centimeter full thickness injuries. And these obviously, the porcine model it's a lot more similar in healing to humans, so it takes a lot longer. So this is treating for 10 weeks, again, once per day topical treatment, and then looking at the scars at the end of that time. And what you can see, so across from left to right, is increasing concentration of the drug. And you can clearly see just from visually how these scars are improving with treatment. And this graph just shows similarly, So we provided these photos to a number of plastic surgeons who were blinded to the treatment group, and they ranked these scars to compare their quality. And obviously, as you can see, so they increased in quality. So the lower the score, the better the scar outcome. And as you can see, that was improving in a sort of dose response fashion. So that was all really promising from that porcine model. And then I'll just talk a little bit about, we've also done a burn model. So this is a burn injury, deep dermal burn injury. And again, topical once per day treatment after time to heal, so after the tissue has reepithelialized. And what we were really interested in here was actually the strength of the tissue. So one of the possible concerns about changing the cross-linking and the collagen deposition and remodeling would be that you actually alter the tensile strength and the physical properties of that scar. So I've got a stress strain curve on the right there of a control and treated. And essentially the slope is kind of a measure of pliability. So the longer that slope or the more shallow the slope, the better the pliability. And you can see there's a slight shift to increase pliability when you treat with the drug. And the peak of that curve actually kind of dictates that's the tensile strength of the tissue essentially. So what you don't want is a reduction in that peak, because that would suggest you're weakening the tissue through treatment. But you can clearly see that the peaks are very similar for both treated and control. So we've got something where we've got very similar tensile strength. So we're not losing strength in the scar tissue as it's healing, but we are improving the pliability. So it's softer and more pliable. And so just to kind of sum up the data that I've shown you. So clearly we can inhibit the target enzyme in scar tissue. We've demonstrated that we can improve scar appearance. And these are assessed by surgeons blinded to the treatment. So I'm pretty confident in these changes in appearance. And we've done that in small and large surgical injury models. And we've also shown that in a much larger deep dermal burn injury model. And the data we have today suggests there's no loss of tissue strength, but there is an improvement in pliability, which is probably the key. The appearance and the pliability are the key properties of scar that matter to patients. So how it looks and how it feels. And we seem to be getting improvements in both those facets. And I think what was really important from that first slide I showed you is we think this has the potential not just to treat at that time of wound healing where you've got sort of weeks to months of healing, but potentially to treat established scars, because that production of collagen and that shift in producing stable collagen persists for a lifetime as far as we can tell. So there's an opportunity not only to treat in the weeks and months after injury, but potentially years post-injury.